My name is Dr. Eugene Tuyishime. I'm Associate Program Director for Research in the Anesthesia, Critical Care, and Emergency Medicine Department at the University of Rwanda. Thank you for inviting me to speak. The title of my talk is The Current Situation of Burnout Among Anesthesiologists. I don't have any conflict of interest to disclose. For this talk, we'll look at what is burnout and awareness. We'll see why burnout matters. We'll look on major contributors to burnout, and we will review how burnout was different during COVID-19 and how burnout is different in the low-income countries. At the end, we'll look on effective interventions and the way forward. What is burnout? You are at a high risk of burnout if you have high emotional exertion and high depersonalization. On top of that, if you have low sense of personal accomplishment, you will have burnout syndrome. What is awareness? Physician awareness is defined by the quality of life, which includes absence of ill-being, presence of positive physical, mental, social, and integrated well-being, experienced in a connection with activities and environments that allow physicians to develop their full potential across both personal and work-life domains. Now that we understand burnout and awareness, why burnout matters? Actually, burnout leads to both personal and professional consequences. At a personal level, burnout may lead to broken relationships, alcohol and substance use, depression, and suicide. At a professional level, burnout leads to a decreased quality of care and increased medical errors. That may lead to decreased patient satisfaction, decreased productivity and professional effort, and increased physician turnover. There are major contributors to burnout. Some of them include workload and the job demands, control and the flexibility on our work-life integration, social support in the community at work, organizational culture and values, efficiency and resources, and meaning in work. If these drivers are optimal, that leads to physician engagement and vigor with dedication and absorption. On the other hand, if those drivers are not optimal, that causes burnout, leading to exhaustion, cynicism, and inefficacy. Here is some examples on how we can improve the situation. At individual level, we may think about the workload and the income, and also our ability to be efficient as we get experience, and also to be able to say no in high workload. And also we need to set our priorities and also have time for our families. But all those good intentions may not be well controlled unless we have the support by the department about also the schedule, the vacation, for example, and also the department may need support from the whole organization because there are productivity targets and also about the salary and also hiring more staff. At a national level, there's an issue of funding, for example, and also to get the supporting staff, funding research as well, and be able to have enough staff in the department. That's why we need interventions both at all those levels, both at the individual level, but also at the organizational level, and eventually the national level as well. How was burnout different during COVID-19? Studies done during COVID-19 showed a prevalence of burnout between 28% to 36%. And burnout was actually lower in the frontline workers in comparison to healthcare workers working in wards. Female providers seem to be more affected, and also healthcare workers exposed to infected patients reported high levels as well. There were many concerns. First, there were limited resources and also limited PPEs, and the response was to provide adequate PPEs. There was a threat to be exposed to the virus, and that's why there was effort to provide access to occupational health services. Healthcare providers worked longer shifts, and as things were being improved, flexible shifts were provided, and sometimes healthy food to the workplace. There was a big disruption to the sleep pattern, and as a solution, lodging and transportation and childcare support were provided when possible. Healthcare providers had anxiety about exposure to family members, and also psychological support was provided to manage the anxiety and insomnia. There was also an issue of neglect of personal and family needs. That's why family support was provided at the beginning, both with food, childcare, and time off as possible. And lack of sufficient communication and updated information during COVID. That's why there was a creation of appropriate communication channels with input and feedback options. And lastly, there was lack of competency during the deployment of some staff. That's why adequate training and access to experts were made available. How is burnout different in low-income countries? Among 65 papers of burnout in Africa, only 8 came from low-income countries, for example, with also a high prevalence of 50%. There was also lack of a contextually relevant measurement tool because the mass-large burnout inventory is not validated across cultures and context. There are also challenges and factors which are unique to low-income countries. Those include inadequate equipment and supplies, low salary, high workload, seeing negative outcomes, armed conflict, shortage of staff, isolated rural practice, lack of control over working conditions, and a high level of poverty. Are there any effective interventions? Actually, interventions at the organizational level showed significant improvement compared with physician-directed interventions. Some other interventions like mindfulness were found to have a very small reduction in burnout. There are some coping behaviors which have been described, including eating a healthy diet, sleeping more, exercising, spending time with family, and building a social and support network, and also developing hobbies. Having a wellness program at the hospital may be beneficial as well. Implementing larger organizational strategies has been described to reduce physician burnout and promote physician engagement. Some of those strategies include acknowledging and assessing the problem, harnessing the power of leadership, developing and implementing targeted work unit interventions, and cultivating community at work, using rewards and incentives, aligning values and strengthening culture, promoting flexibility and work-life integration, providing resources to promote resilience and self-care, and facilitating funding organizational science. It is important to note that these strategies were developed by authors from high-income countries in high-income settings. These may not be applicable in other different settings, especially low-income settings, and efforts are needed to adapt or find applicable solutions for those settings. Another proposed approach was proposed by Chapiro and colleagues, which provide hierarchy order of needs, similar to the Maslow's hierarchy of needs, starting with the basics, including, for example, food, and also rest, mental health support, and also safety, going to the higher level with respect by the colleagues and also administration and appreciation, and also having the resources to manage and heal patients. What can we do from here? I think burnout prevention and awareness should be a priority at both individual and organizational level in order to mitigate negative consequences of burnout syndrome. Availability of wellness programs should be encouraged among all anesthesia departments, and also more studies are needed in order to better understand burnout in the context of low-income settings. Lastly, wellness interventions should be adapted to the context of each anesthesia department, each hospital, and each health system. Thank you. For further questions, you can contact me at my email at trishimi36@gmail.com. Thank you.